So it's great to be back here on the podcast with Dr. Caroline Walker. This is, I think, the third episode that we've done together now, all about supporting doctors through the COVID crisis. Caroline, do introduce yourself.
Hi, I'm Dr. Caroline Walker. I'm a psychiatrist and specialise in doctors' wellbeing. I founded the Joyful Doctor, which is an organisation that's all about kind of helping doctors with their wellbeing.
Thank you. And I'm Rachel Morris. I'm a GP and executive coach, and I specialise in resilience in the workplace. I'm the host of the You Are Not a Frog podcast, and I also run an organisation which specialises in wellbeing in the workplace for doctors and other professionals in high stress jobs. So we have a training course called the Shapes Toolkit. So we have been talking a lot about, well, the mental health of doctors and staff on the front line, and how we manage our stress and anxiety. The last one was about how we deal with our anger, our sadness, and our grief through the crisis. And we're going to keep putting these episodes out. We've had some great feedback from people that they've been very helpful. And what we wanted to discuss today was the concept of moral injury. There was a BMJ paper out just a few days ago talking about this. And, I thought that it would be really good for us to explore it and work out actually what is it that we can do to, well, either prevent it, or if we can't prevent it, to minimise the effects on us. So Caroline, you know a lot more about this than I do. What is moral injury exactly?
Well, moral injury is a relatively recent term. It's only really been around since the 1990s, and there's still a lot of kind of debate about what, like, a particular definition for it. But essentially, it's what happens when we witness something or we can't stop something from happening that goes against one of our deeply held moral beliefs. So we're seeing a lot of this, obviously, at the moment with COVID-19, with doctors who are primarily, really wanting to put patient care first, but having to make some really quite difficult decisions about rationing care, or perhaps not giving the care that they would like to be giving for various reasons. So yeah, it's essentially when something happens, we either witness something or we can't stop it from happening, or we're making it worse ourselves. We're somehow contributing to it. Something that goes against something that's really, an important belief system for us.
Yeah. So even though it's a new concept, I'm presume that it's been happening for decades and for donkey's years.
Yeah, absolutely. I think since human beings have been around, I think we've experienced it, but I think it came to light as an idea through the sort of 20th century with the world wars and the later wars like the Vietnam War and stuff. It became a sort of more talked about concept amongst sort of the military. But in recent years, it's been talked about more and more in healthcare settings, because it's obviously a very common thing that happens for healthcare staff. So
before COVID, was it happening a lot, or what's your concept on how much it was happening?
Yeah, absolutely. I mean, it happens in everyday practice, I think, unfortunately, in healthcare. And there's some sort of suggestion now that it may be linked to burnout. There's quite a lot of crossover with trauma and PTSD. And I think we're still trying to understand, where it kind of fits and what it means for us and how we can best help ourselves. But it's absolutely something that we're seeing really front and centre in the current COVID-19 crisis.
Yeah, and I guess there's all sorts of reasons for that, aren't there? And it's not just about, I guess, those ITU decisions about who do we resuscitate, who don't we, which just must be the most difficult thing. But it's also just those little things, I think, in the not being able to give the same care. I know for GPs, everyone's had to go to video and telephone, and whereas you'd once bring someone in and examine them properly and be able to spend, I guess, a bit more time with them, or, at least some sort of face-to-face contact. We can't do that anymore. And so, it's even getting hard to do blood tests at the moment and things like that. So actually, things that before were absolutely set in stone, that you must do this every week or every month with patients, we just can't do. So it's not just the acute stuff, it's some of the chronic disease management that we we were once told this is really important, and now it's sort of all gone out the window.
Yeah, absolutely. I mean, most of us have gone into medicine because we want to care for people. So it's a really fundamental part of our psychological makeup, you know, to do the very best we can for our patients. And then that's kind of instilled in us throughout our medical training. And then we take an oath, don't we? A Hippocratic oath to do no harm. So then when we're faced with that situation where we're perhaps having to withhold care from somebody that we know in other circumstances we could give that care to, it's really, really, really difficult, very, very, very emotionally straining. And what I'm seeing is it's happening, as you say, in really subtle ways all the time already. So I was speaking to a GP this week who their practice, like many, has had to kind of reconfigure itself, join up with local practices to think about how they fight against COVID at this time. And so out of hours, a lot of her patients are being seen by other GPs. So these are people she knows really well, that she's cared for many years and has a relationship with. And she wants to be the one making those decisions for those people at those crucial points in their journey, you know, whether they get care or not. And but it's being done by other people. So there's these things happening. She's witnessing, you know, these choices being made about these patients that she cares for, and she hasn't got the agency to step in or do anything about that. So it doesn't even have to be something that you are directly involved with. It can be something is happening in your kind of sphere of, you know, influence or with your patients you normally see. So yeah, I think you're right. I think it's happening in lots of really subtle little ways, and I think it has this kind of eroding effect over time, that it really starts to wear us down. You know, doctors, we've all been trained and all probably had to break bad news at some point, had to sit with families and explain to them why we couldn't save their loved ones. But doctors right now going through this challenge are going to have to be doing that day in, day out, repeatedly, over and over and over again. And I think that's going to be really, really quite challenging for most.
So how would you spot if you've had a moral injury, or, you know, is it something that you really feel at the time and then you start getting symptoms, or does it build up over a while? Or
I think some of them are really obvious, like some of them hit you in the face, like, this is so wrong, I can't take this, I can't believe I have to say this or not do this, or do this, or this is happening in front of me. So some of it we're really aware of and it's quite obvious. A lot of it is happening we're not even really aware that's what's happening, but we're just left with this slightly uneasy feeling, or we kind of get home at the end of the day and maybe we're, you know, reaching for that glass of wine, or the extra glass of wine that we wouldn't normally have, or eating a little bit more chocolate, or, you know, it'll start to show in our behaviours that something isn't quite right, but we haven't quite noticed it. So I think it's both. I think we'll see some of it, but we won't see all of it. So I think having a kind of a quite sensitive radar on at the moment, to just be like, oh, could this be moral injury? Could this be something that's jarring with me on some level? Might be helpful. Just to be able to name it and acknowledge it, I think is quite helpful.
So that was my next question, is actually what can we do about it? And I guess there's the, you know, we go down the whole medical route, you've got to prevent it first, you know, and then you sort of try and alleviate it, and then you treat it if you've got it. I don't think we can prevent it. I think it is a natural, normal part of everyday healthcare anyway. And I don't think we certainly can't prevent the kind of increased level of moral injury that we're going to see over the coming weeks and months through COVID-19. I think we can prepare ourselves for it. So I think we can as a profession, and I think we are doing that to some extent. So there was some guidance released a couple of days ago by a lot of the Royal Colleges have got together and produced this kind of ethical guidance for doctors around, you know, how to make these really quite difficult decisions around patient care. So I think we are starting to look at it and start to kind of acknowledge that it's there. And I think it's not about, you know, this isn't going to happen, because it's already happening. We can't stop it from happening, but I think it's about preparing ourselves, saying this is happening, having strong kind of leadership. I think as medical leaders, we need to be saying this is happening and it's okay, and we're in this together. We are all experiencing this. This is not something that we need to hold as individual
doctors and practitioners, because I think that's where it can get really quite damaging if the individual feels like it's their fault or it's something that's they're doing. If they take this personal responsibility, which a lot of doctors tend to do, and healthcare professionals. So I think it's really important that we name it, that our leaders kind of are in it with us and say, it's okay, we're going to do this together. And the guidance that is coming out and what we've learned from over the years of what helps with facing moral injury is, just don't do it alone. Don't hold this on your own. Do this together. Walk it through if you want to with someone. Share the decisions.
Yeah, I think that idea of sharing the decisions is really important. And guidance, because I can imagine if you have really black and white guidance that says this is what you've got to do and this is why, here's the rationale behind it, that actually maybe withholding treatment probably would have been futile anyway, or it was unlikely, so you can understand the decision you're making. There's clear guidance, so someone else has made that decision for you, so you're then following the clear, as long as you trust the source of the guidance, I guess, as long as it's, that it's been really thought about in an ethical way and they've looked at the population. I'm guessing that must be a lot easier than having to make a decision just on your own on the back of, oh crumbs, what feels like the right thing to do.
Yeah, I mean, I think the guidance that at the moment is saying, we have to still make individualized decisions here, as in for the individual patient, but that we make those decisions as a team. So we talk about them and we discuss them, and what they're trying to do, certainly in the ITU situations, is to have ITU input on those sorts of life and death withdrawing or withholding treatment, because those doctors and nurses are used to those sorts of decisions and helping make those sorts of decisions and thinking about the complexities involved. And so I think it's a kind of a mixture. It's about saying each individual case is still important to think about, but don't make that decision about that one case on your own. Do it as a team.
So get support, do it as a team. What about for people who are, I'm just thinking of doctors manning the 111 helplines and GPs on their own in surgeries doing video, so they don't necessarily have a group of people on their own to help them, a group of people around them to help make these decisions. What would you say to them?
Well, I would say actually you probably do have some support around you that you can access and use. So everybody in these situations will have access to supervisors, or have peers and colleagues in the room next door, or sitting on the phone next to them, and it may be that you're not able to sort of talk about something in that moment, but when you step away or you take a break, there are always people that you can talk to if you feel able to. So if something's just happened that's really not sat well with you and you're just feeling like this is really unfair and I can't bear this, and I just share that and talk with whoever's there and whoever you feel safe to talk with. And so it might not be that you've got somebody literally stood next to you making that decision while you're speaking to the person on the phone, but when you put the phone down, you can then go and talk through what the decision you've made, and that's going to help you, because these aren't going to be isolated incidents. These are going to be things that people are having to face and to think about like many times a day for many days on end over weeks and weeks. So even if you haven't had a chance to kind of reflect in the moment on that particular case, it's always worth having a think or chat with someone about it outside of that, because then it can help you for the next time.
So it might be good to jot down the things that you need to talk to somebody about. So I'm thinking actually a lot of GPs now are actually working from home, so they're doing remote consulting. They don't even have anyone in the same building. But they're also busy that what they're not doing is making sure that they regularly get a check-in chat with their colleagues.
Well, we talk about this quite a lot, don't we, Rachel? We recommend teams do put in check-in chats, and a lot of medical teams are having a lot of success at the moment with having little online like Zoom meetings for 5 minutes, 10 minutes at the beginning, end of a shift, because I think it's so important that we still maintain that team approach, so that again you don't feel isolated and like you're the only one that's carrying this burden.
Yeah, absolutely. I mean, I think it's important in if you think back to normal life, you think back to pre-COVID, certainly GPs, a lot of GPs had got out of the habit of the regular coffee break, the regular chat together, the regular debrief, because they were just so busy. And it's the one thing that I've been banging on about, you know, the importance of this. And you know, and now I know that it's actually important in moral injury, is sort of got even more important. You know.
I'm often asked, you know, what's a joyful doctor, what's joyful doctor all about, and one of the things that I've noticed as I've gone about you know, working with doctors over the years, is the happiest doctors, or the most well doctors, mentally and emotionally speaking, are the ones that have those things in place, have those regular check-ins, have that sense of, you know, normal human connection to their peers and to their colleagues, and that's a day-to-day practice, but also kind of regularly outside of it as well. You know, maybe having a group of 2 or 3 people that you really trust and like, that you do a Zoom call with once every couple of weeks or something, or, you know, those things are even more important now. I think, with the sheer volume of these sorts of experiences that we're going to be going through as doctors.
100% agree. So connection, one of, you know, my wellbeing, resiliency, protective factors, it's the number one factor. It's got the most evidence behind it. And actually there's a lot of evidence that not only does it help you debrief and I guess help sort of prepare and prevent moral injury, but actually helps with productivity. You know, the teams that chat together regularly and have informal interactions are the teams that actually perform the best. So there's all sorts of reasons why we need to have these chats, and we've got some guidance on those, and I'll put that in the show notes as well, so people can download on how to have that. So back to moral injury. So we're talking about how to prepare for it. So you talked about some ethical guidance that's come out. You talked about strong leadership. You've talked about naming it, you know, saying this is what's going to happen and being prepared for it, and being in it together. So don't do it alone. So to talk things through and have discussions. Is there anything else we can do to prepare ourselves for this?
I mean, I think at this stage, at this kind of first acute phase of the first few weeks and the first couple of months of COVID, the most important things are still the very basic physical needs, actually. So, you know, making sure that we're well rested, that we've got the protection we need, that we feel safe. So I would say at the moment, we don't need anything particularly fancy. I think it's about keeping ourselves feeling physically and emotionally safe. I think it's worth knowing at this stage that if you develop problems down the line with this sort of issue, so if you're really preoccupied by the moral injury type experiences, if you're feeling really traumatized, if you're feeling, you start to get increasingly low mood or problems in a more general way with your mental health, then there is support out there for you. So most of us, it's important to remember, will experience some unsettled mental health type symptoms through this COVID period. Most of us will feel a little bit stressed, a bit hyper-aroused, we might have some trouble sleeping, or we might be a bit preoccupied, most of us will have some low-level symptoms, and they will tend to settle down over a few weeks to a couple of months. But for a few of us, they'll get more kind of severe, persistent problems, and that is absolutely okay, and there is help out there for you for that. So if you're finding that you need that little bit more support, then please know there is support out there for you. There's going to be some signposting, some announcements in the next 24 to 48 hours about national level support for frontline staff. So keep your eyes peeled for that, and we'll be flagging that up everywhere. So if you're following either Rachel or I on any of social media platforms or these webinars, we'll be flagging that up as well. But there's going to be a lot of support out there. There's a lot of need for mental health support at the moment, but it's being met by a lot of people who are working really hard to make sure that need is met, and there is support for those who need it.
So if someone was to contact and want some support, what would they expect in terms of, if you're giving them support for moral injury? Is it the sort of post-traumatic stress syndrome type treatment, or what would
Yeah, so it's going to vary depending on the individual and what their situation is. And I think for most of us, what we'll probably need is just a bit of a safe space to just talk and share our story of what we've seen and what we've heard and how we're feeling. And for most of us, that'll be enough. You know, just a sort of safe environment in which to just kind of offload, to vent, to share our feelings, to feel heard. And to have that normalized, and for most that will be enough. For some, I think it's important they're going to need a little bit more support, and they'll need to be assessed individual by individual, because for some it will be maybe they might have a more anxiety based picture which is kind of supported and treated one way. For others there might be like a PTSD or post-traumatic stress disorder type picture that's treated another way, and for others it might be more grief or, you know, other mental health problems. So I think it's important that we sort of normalize most people's reactions and provide a sort of general safe place that people can go and just share and talk and get some sort of basic level of human, you know, compassion and support. And then for those that have got perhaps more severe or persistent symptoms, to have a proper sort of assessment by an experienced individual, by a health service that's set up for that in particular, so that we can find out what is it exactly that's going on for you, so we can make sure you get the right treatment, because there's going to be a different approach for different people needed. Yeah.
So just the message to people is really get support where you need it.
Yeah.
No point soldiering on on your own, thinking I'll be fine. We'll just wait for this to go away. It'll be okay.
And at this stage, I think mostly that's going to be, you know, talking to your colleague in the 5-minute break that you managed to snatch, you know, in between your crazy busy shift, or talking to your loved ones when you get home, talking to a friend, or, you know, it doesn't have to be professional. It can be that kind of, you know, just everyday support. I think is really important that we value that and use that. But if you're needing or you want a sort of a space with a professional, then there are going to be support services out there. And I'd signpost doctors and in fact all frontline staff at the moment to the Practitioner Health website. So practitionerhealth.nhs.uk. They have a COVID resource page, and that's being updated every day, and they'll have the national response stuff on there once it's announced. So if you keep an eye on that page, that should signpost you pretty well to what you need.
So Carolyn, if you were a team leader, so I know a lot of our listeners are A&E consultants or IT consultants, or they're leading within a GP practice, what things would you say, right, let's get this in place over the next few days to try and help with all of this stuff? What's the really helpful stuff?
So I think you cannot underestimate the very simple, very human role modelling. So even just, I mean, we're all kind of disconnected at the moment, working in different environments. Even just a little email just saying, we know this is a really tough time and we're all in this together. You know, I think it's those simple things we often overlook. And as doctors, we're often looking for those sort of the fancy resources we can signpost to, and the step-by-step things that we can kind of go through to kind of cope. And we miss those, we forget to do those really simple little things, to just share, to just say, God, this is really tough, isn't it? But, you know, we are in this together. And if anyone's struggling, please let me know. You know, that stuff is priceless and will probably hold most of your team, actually, without them needing much more sophisticated input. Just knowing that somebody is thinking about them, that somebody cares, you know, that they're not being taken for granted, that they're being valued, that they realise that this is really tough. And using words like we rather than you. You know, you might be struggling, you this, you know, it's actually, no, we might be, because we're all in this together. From the, you know, very bottom of the hierarchies right to the top. This is a great leveler, this experience, isn't it? So I think start with those things, you know, the really basic things. And then you can look at building in, you know, I know a lot of trusts and teams are building in website pages, signposting resources, you know, that's fantastic as well. But don't forget those really simple human touches.
I would sort of offer a word of caution as well, because I've been coaching a few sort of leaders who have just exhausted themselves by trying to support their team. So they are so compassionate and so amazing that they're,
Yeah.
you know, making themselves uber available to their
Yeah.
team, which is absolutely fantastic, but it's taking all their time and it's very draining for them.
Yeah.
And I think, you know, I was talking to someone yesterday about how sort of they can put in some boundaries around that, and she ended up saying actually that the check-in chat would actually cover quite a lot of the one-to-one things, you know, and if you do a regular check-in chat, maybe just every day, once or twice a day, just 5 minutes with the whole of the team, then actually, you know, the team can start supporting each other. And I think sometimes we forget to use each other, and the leader feels it's all on them to support everyone else.
Absolutely. I think it's about getting strategic about how you use your time and your resource. So keeping it human, so that it feels like you're connecting on a really one-to-one level, but actually, like I've been using a lot of when I've offered somebody some support by email, for example, I'll then copy and paste that, and I'll make that into like almost like a template that then I can send to other people, so I'm not typing out the same thing all the time. And you build those little systems, you know, and you signposting, and I think my feeling is for leaders is, you know, role model it and that people then will get on with it, because most people are naturally wonderfully compassionate and supportive of each other in healthcare, given permission to be that way. So I think it's setting the example, and then as you say, kind of empowering your team to look after each other and themselves.
And so you might need to put some structure in around that. You might need to say, right, every day at X, here's these 2 times we're going to do the check-in chats, here's the Zoom link, this is what we're doing. And even if you can't be on all of them, that's been set up. And leaders need to go on those check-in chats.
Yes, 100%.
If they just leave it to the teams.
I once attended a mindfulness course actually where a CEO came, but they only came for the first one. And the message that sent was so powerful. It was like, you're kind of in this together, but no, we're not really, because I'm too busy. It just so I think it's really worth thinking about how you're showing up as a leader, actually.
I've delivered resilience training where the team for a team where the team leaders just sat out at the back on their laptop and let the team do it. It's been like, really?
And it's hard because we're all busy, we're all stretched, right? And I think so it's about, if you can build in enough headspace for yourself to just even think about your processes around this stuff, it's going to help. So where can you delegate? How can you have the smallest intervention but with the most impact?
And I think with leaders, that's interesting about the delegation, because as a leader, your Jedi skill might not be sort of support, you know, pastoral support. And so if that isn't your Jedi skill, find the person in your department who it is, get them to do it, but make sure you're 100% behind it and attending all the stuff and really pushing it forwards.
And also helping them, as you said, not to get sucked in to delivering it all themselves. We're much more effective. I've done a lot of work with doctors over the last 2 or 3 weeks to help them to take a step back, because we tend as doctors to kind of rush in, don't we, and just be like, oh, I'll do this, it'll help with this, and actually we're much more effective if, like, you know, when you go to a CPR training, you know, what's the first thing you do? You don't jump in and start doing CPR. You look at the situation and you think, is it safe? And I think that's what we need to be doing at the moment. We need to be stepping back and going, okay, let's see the bigger picture here. COVID isn't going anywhere. These staff are going to be struggling for a long time. You know, it's not about what I do today. It's about what we do every day for the next few weeks and months. And what could I do today that's like a little tiny thing? Maybe just send one email that just says, look, we're thinking about you and we're putting together some resources. So they know it's happening. They feel kept in mind. They've got a safe place to come if they are struggling to get signposted. And then you set those processes up that are going to kind of hold people in the weeks and months to come.
I think it's so important to be strategic about this, you know, just as you have a plan for your department or your practice about hot sites, cold sites, how you're going to do the infection control.
Yeah.
You need to have a plan about how you're going to do the wellbeing control.
Yeah.
as it were. And it's never been more important than now.
This is, I mean, more and more I'm seeing this is a mental health crisis as much as it is a physical health crisis. Absolutely. And if we don't think about how we respond, and we just fall into those habits like doctors of just give, we are going to fall apart. Yeah. And that's going to help nobody. So we have to kind of look after our own well-being first, and then
so we have some resources that can help. We've developed there's a team wellbeing toolkit, so if you want to download that, do. It's got information about how to have a check-in chat, some basic physical workplace stuff, some stuff about the ABC of being active, taking a break and connecting. That's, I think, your basic team wellbeing stuff, and then some sort of rules about coping with COVID. And there's some other resources, Caroline.
Yeah, we'll be putting out a resource pack in the next week or so. Some posters you can print up and put around your workspace, or send around electronically. So if you're following us on any of the social media channels or on either of our websites, you'll be hearing all about those.
So we'll make those available to you in the show notes link. And just, I think, I'll ask you in a second, Caroline, if you could do one thing. If you could do one thing, it's put in those regular team check-ins where you are, and where you're focusing not on the how you're managing the illness of COVID and stuff, but you're focusing on the well-being of the team. And you ask your 4 question, which is, how are you really? What's worrying you at the moment? What's going well, and what do you need? Those 4 questions will just allow people to open up. And you don't need to solve them. You're not there to say, oh, okay, we'll do this for you. You're just there everyone's there to listen and acknowledge. So that's if you do one thing, you do this. What's yours? If you do one thing, do this, Caroline.
I think mine is just don't do it on your own. I don't think it matters who you take it to or who you share it with, but whether it's in person with your loved one at home, or a colleague at work, or a professional, or you on social media, or connecting with people, just not doing it on your own, not carrying this extraordinary experience and this burden on your own, because we're not in this alone, we are in this together. This is happening to all of us, and as a profession we're sharing that burden.
And just a note on that, don't do it alone. I think it is really helpful. It's really helpful to connect with friends and colleagues and family and stuff, but actually in circumstances like this, you do need to connect with people that are going through the same sort of thing. Because I think it's very difficult for people that aren't just sort of at home, they're not seeing the same stuff as you. They're not going to have quite the same experience, and they can't quite share that with you. Do you agree?
Yeah, absolutely. I think both can be really helpful, but absolutely, it's nothing like somebody who gets it. To share a burden with. So, and there are a lot of us out there that get it. I think pretty much every NHS frontline staff member is going to be experiencing similar things. So.
Okay, great. Well, Caroline, thank you again for sharing your wisdom with us. We'll put links to how you can get hold of Caroline, how you can get hold of me, how you can get hold of our resources. If this has been helpful for you, then please share it with other people. Please feel free to share it widely, post it on whatever websites you like. We're here. We want to be providing as many helpful resources as we can. So please get in contact with us if there's something you'd like us to cover that we haven't already covered. We can certainly do that, and you'll certainly be hearing from us again pretty soon. So Caroline, thank you.
My pleasure. Thanks for having me.
Cheers. Bye.